So do you also work weekends also, or is it
When
just
I'm
5 days
yeah,
when
when
you're
I'm
on call?
on call, I do. Otherwise, like when I'm not on call, my weekends are off.
That's great. That's
Yeah.
that's great. Yeah, we'll just give it. We just went live, but we'll give it another minute for people to come in and
Okay.
get settled. Guys, we'll get started about 8 o'clock. In the meantime, if you guys have any questions, just drop them in the chat. Drop them wherever you guys are from and what point of schooling you guys are at. Like, are you guys in high school? What grade are you guys in? Just drop that in the chat. Always helpful to see what who's here, what's going on. All right, looks like we're right on time, so I'm just gonna get started. I'll get into the announcements a little bit like I always do, just to make sure everybody's clear on what we're doing. So this call is today with Dr. Patel, and it's going to be about 45 minutes to 1 hour long. And we'll take any questions that you guys got. Just drop them in the chat as we go, and we'll try to get. I'll try to ask as many as I can, but yeah, feel free to drop anything you guys got. A little bit about for those who are new, this might be helpful information. For existing members, you guys probably know a lot of this. So, but I do see a lot of questions normally in the call about this, so I'll just get this straightened out in the beginning. So this, like I said, the call will be about 45 minutes to 1 hour long. You can verify your hours. And why would you might want to verify your hours? So like, depending on what school you go to, you might need to report a certain amount of hours to your program. So this is a great way to do it. For our verification, we ask that you write a small summary, about 3 to 5 sentences, any format, just talking about what you took out of this meeting, what you learned from Dr. Patel and the information that he presented. And you can just send that over um, via email. Our email is clubmedshoot@gmail.com. And all this information that I'm talking about is posted in the bio. And all the summaries, if you've been compiling on, they're going to be due soon. June 15th is the hard deadline that we're putting up. So all calls from the beginning of January up until June, you guys can send them all together if you'd like. But also you can, like I said, you guys can also send them week by week basis. Everybody's got different requirements, so we understand that. But for us, it's usually faster if you have them all together at one point, and we can just do them all together. We're just doing this by hand, so it goes a lot quicker for us. But whatever you guys feel comfortable with, go ahead with it. We also have volunteering opportunities. I know COVID has impacted that. The situation is still kind of different depending on where you're at. Some places are allowing it, some people's not. So, but if that's something that you need, like your hours, check us out on the official Club Med volunteering page, and all the opportunities that we have, like the different programs. All that information is posted in the bio. So check it out, and all information about how to sign up those is also posted on bio. And if you have any questions about like anything about the volunteering program, DM them on their Instagram. But if you have any questions about Club Med in general, DM us on our Instagram at official Club Med, and we'll get back to you as quickly as we can. So that's it for announcements. Now it's time for our presentation. Today we have a very exciting guest. His name is Dr. Chirag Patel. He's a medical doctor. He's out from Orlando, Florida, and he's a board certified ophthalmologist. He does private practice and also works, does like emergency cases, and works in a hospital too. And his Instagram is up on the screen at Nona IMD. So be sure to follow him. He posts a lot of cool stuff on there. So be sure to check him out on his Instagram and follow him. Dr. Patel?
All right. Thank you guys so much. Give me 1 second here. I had a little snafu with a video I embedded. So I'm going to share my screen here in just a second. Thank you guys so much for giving me this opportunity. I think this is amazing, especially when the pandemic happened, it makes your journey through medicine very, very difficult. And so Club Med, I applaud you guys for coming up with an innovative solution. I think that's something that is welcome. So let me share my screen here.
Guys, while he's doing that, like I said before, if you guys have any questions, just drop them in the chat as we go, and we'll try to get them all answered as quickly as possible.
Perfect. So do you guys see my screen?
Yes.
Okay, perfect. So again, thank you so much for introducing me. So I'm Chirag Patel. I'm an ophthalmologist, and I practice in Orlando, Florida. And for a lot of you who may not know, I'll just be super simple. An ophthalmologist really is a medical doctor who specializes in the medical and surgical treatment of the eyes and the eyelids. And that's different from an optometrist. They are not medical doctors. And so they typically are kind of uh, screening tools, primary care, so to speak, for the eyes and the lids. But an ophthalmologist is a medical doctor, and so and so that's kind of what we do. So my journey, it was long, but it was totally worth it, and I would do it over and over again. And so a little bit about what I've done. I went to the University of Florida for college. Got a major in biochemistry, and I also did a minor in business. I ended up going to medical school at the University of Florida, stayed there for another 4 years. And towards the end of medical school, it's funny, our program director at the medical school was like, all right, Chirag, he has meetings with everyone. And I really was not sure what specialty I wanted to apply to, what residency I wanted to apply to. It was really, really difficult. I liked a lot of things going through medical school. I jumped from cardiology to radiology to surgery. And then, when my last rotation in my third year of medical school was surgery, and we had a 2-week subspecialty where we could choose. So I chose ophthalmology and I chose urology, and definitely didn't like urology. A lot of long surgeries, and just kind of wasn't something that excited me. But ophthalmology was something that was kind of cool. I always wore glasses and contacts growing up, but I really wasn't truly exposed to the field. And so, when I said, all right, this sounds kind of cool, I kind of just took a leap of faith and I said, that's what I'll apply to. So ophthalmology actually ends up being one of the more competitive fields to match into during the matching process. And so there's an acronym that they always say, there's the road to success, and it's radiology, ophthalmology, anesthesia, and dermatology. So those are kind of the very, very four most competitive residencies to get into. And because I decided late, I was kind of nervous and scared, but I always tell everyone everything works out. I applied to a whole bunch of programs. I had competitive scores. I did well during medical school, and I ended up matching at Mount Sinai in New York City, which is a great ophthalmology program. So after medical school, I ended up doing an internship. When you do your internship, you can do your internship really in anything, internal medicine, surgery. There are something called a transitional year, where it's kind of like the third year of medical school all over again, where you do a little bit of everything. But because ophthalmology is a surgical field and there are a lot of tie-ins with medicine itself, meaning internal medicine, I chose to do a residency, internship, excuse me, in internal medicine. So I was in the ICU about 6 months out of the year, did a lot of ambulatory care, inpatient care, and it was really, really good. Learned how to manage, hypertension and diabetes and those types of things. And then I started my residency, which was 3 years. Ophthalmology residencies are 3 years long, and they're typically structured in an outside-in process. So what that means is, as a first year resident, you're really just learning how to really examine the eyes, really becoming an expert in examination techniques, and doing stuff on the outside, small eyelid lesions, styes, those types of things. The second year, you start doing things that are a little bit more in depth, and you get into the subspecialties of ophthalmology, more retina disease, pediatrics, those types of things. At the end of the second year, you start learning how to do surgery, so ocular surgery. So during the second year in the beginning, you start doing surgery on the surface of the eye, like LASIK and pterygium surgery, those types of things. Towards the end of the year, obviously, the most difficult and challenging part of of ophthalmology is intraocular surgery, microsurgery. So that's what you learn towards the second year and all through the third year. When I was a chief resident, that's kind of all you do is operate. And so at the end of my residency and whatever specialty, just as a side note, you guys decide to go into when that time comes, always think about, in my opinion, the best places to go train are places where you want to finish and say, I've seen and done everything that I could, and I'm confident that anything that walks in my door, I've seen it already. And that typically happens in a lot of metropolitan areas. Frankly, being in New York City, I saw tons of, everything from immigrants to wealthy people to people who literally just came off the plane and having issues with their eyes. And so, it being such a populous city, you really were exposed to a beautiful diversity of demographics, a beautiful diversity of pathology, and that's really, really how you learn. And then I ended up doing a fellowship in medical retina. So medical retina is a little different. It's not surgical retina. Medical retina basically is how to treat retina diseases of the eye medically. So either by injections or lasers or those types of things. So I did a year of that. And I stayed on at the University of Florida as an attending, as an associate faculty member. And I taught residents how to do surgery and had my own clinic. And that was a great experience, kind of being out on my own. It was a nice bridge. I was seeing about 50 patients a day. It was super, super busy. But what I kind of learned was that even though I did a fellowship in medical retina, I really missed the comprehensive part of ophthalmology where I could kind of pick and choose what I wanted to do and kind of really approach the whole breadth and depth of the field. And so about a year and a half afterwards, I kind of decided just to do my own thing. I grew up in Central Florida. And so after being in Jacksonville for a couple of years, I said, well, I want to kind of open my own practice. So I opened my private practice just on my own about 8 years ago in 2013, and been going on that journey since then. And it's been amazing, just kind of seeing your own practice grow and practicing medicine the way you want to practice. I think that's really important. There's so many political and organizational changes that happen in medicine, and a lot of people have become cynical about medicine as well. But I really think that it's an amazing field, and you can still make what you want of it. And again, I would do it over and over. So my typical schedule, for the most part, on Monday through Friday, 8:30 to 4:30 or so is usually what I work. On my surgery days, a little earlier, I usually start surgeries at around 7 or 7:30 when I'm in the operating room. I operate about 6 half days a month. So being that it's my own practice, I like to make sure that I am in the office at least part of the day, every day of the week. And so I like to operate on half days. Our surgeries are pretty quick. So 15, 20 minutes for a typical cataract surgery, about 30 minutes for a pterygium surgery, a little longer for a blepharoplasty, eyelid surgery, those types of things. So on a given day, on a half day, I can do about 12 to around 10 to 12 cases in a half day. And then I go back to the office to see patients. Average surgical volume is around 50 to 60 cases a month. And so, that definitely, it keeps me busy. One of my surgical days is dedicated to oculoplastics, which I'll talk to. So that's really more of the cosmetic part of ophthalmology. The average number of patients, typically anywhere from 30 to 40 patients, so about 35 patients a day. I do choose to take trauma or emergency call through the local hospital systems. And so the local ophthalmologist typically will divide the call, the 52 weeks of the year up between all the local ophthalmologists, and we'll take call for a week at a time. And it's great. Sometimes it's super busy. You get a lot of trauma, and sometimes it's pretty slow. But it's definitely a great experience to kind of continue to sharpen your knives, if that makes sense. So why is ophthalmology so amazing? And it's technology driven. It's rapidly evolving. You have the ability to absolutely make a significant impact into the lives of patients surgically. You have long-term care and short-term care. You get to collaborate with so many different other specialties in medicine. So you're not in your own bubble, despite what people think. I talk to rheumatologists all the time. I talk to patients' medical doctors all the time, internal medicine, endocrinology. And so that's a great part of our field. Other things are that you can actually diagnose. You can be the first person to diagnose a major systemic disease just through something that may be going on in the eyes: rheumatoid arthritis, lupus, ankylosing spondylitis, multiple sclerosis. So there's so many things that will present as an eye symptom, and it ends up being something more global that's going on. And it never gets boring. There's a lot of variety in the field. So ophthalmology has about 6 subspecialties. Comprehensive is generally, obviously, whatever you are comfortable doing. That is, a general ophthalmologist can really do anything based on what they're comfortable with. But you have oculoplastics, which is basically the cosmetic and reconstructive surgery of the eyelids and the brows and the orbits. You have glaucoma, which is a subspecialty that deals with patients who have moderate to severe glaucoma. Retina and uveitis is a field of ophthalmology that deals with patients who have severe disease in the retina from diabetes, strokes in the eyes, patients who have macular degeneration or inflammatory conditions in the eyes. Cornea, those are specialists in the very front part of the eye called the cornea. They take care of a lot of corneal infections from contact lens wearers. They specialize in LASIK and cataract surgery as well. Pediatrics is a field of ophthalmology that deals obviously with kids, but mainly kids who have lazy eyes, amblyopia, eyes that are deviated, turning out or turning in. Those are really, really important because visual development is so critical during the first 8 to 12 years of life that if it's not treated, patients may not develop their full potential vision. And then neuro-ophthalmology basically is a blend between a neurologist and an ophthalmologist, and they deal with certain diseases of the eyes and the brains, like something called pseudotumor or multiple sclerosis, etc. Okay. If you guys have any questions, just pop in.
I got one question for you, Dr.
Yeah.
Patel. So during your scope, the 8 years that you've been practices, like what advancements in technology have been made in terms of how you can handle, or just in general in the last 10 years that you've seen that has impacted?
So there's been amazing, and it's funny, I know some of you may be still in college or even high school and going through physics, and I actually didn't really like physics much going through college, and especially optics. And now look at this, I'm dealing with optics all the time, and I actually love it now. I really, really love optics, and that is a lot of where our technology is driven. So for instance, and I'll talk about this in a little bit, but cataract surgery, when we do a lens replacement surgery for patients who develop a cataract, these lens replacements are amazing. They use principles of diffraction and they use principles of refraction to be able to give patients amazing visual ranges, visual quality. They minimize chromatic aberration and all of these other things to really restore sight, which is tremendous. We have now the ability to treat macular degeneration, which otherwise really was a blinding condition. We're able to inject a specific medication in the eye called Avastin or other types of anti-VEGF medications that slow and dry out the retina And that was basically a cancer drug that they basically said, hey, that kind of looks like what happens in the eye with macular degeneration. What happens if we inject it into the eye? And it's been a success story since then. Other things are different types of lasers that we use. We use a femtosecond laser, which is a millionth of a billionth of a second fast.
Wow.
And we are able to make such precise incisions into the cornea, into the eye, to treat astigmatism and to treat all these other visual problems. So it's pretty amazing.
Gotcha.
So, okay. So what I do, I'm actually, even though I'm fellowship trained, I am a comprehensive ophthalmologist because I really missed kind of doing a little bit of everything. I had a lot of oculoplastic experience during residency. I worked with some amazing oculoplastic surgeons and I got a ton of experience with them. So I really enjoy doing oculoplastic surgery, blepharoplasties, eyelid surgery, both cosmetic and reconstructive. I do a lot of cataract surgery, and that's something we'll talk about in just a bit. I do see about 15% of my practice is glaucoma, treating early glaucoma and screening for glaucoma, and then obviously medical retina. We get patients all the time for diabetic screening. Diabetic patients need to have their eyes checked once a year, and so I'm always examining their eyes to make sure they don't have bleeding or swelling. And I get to counsel those patients. Hey, how are your blood sugars? Are you controlling your sugars? That kind of makes me feel like their medical doctor, kind of going through that type of counseling. And so would I do this over? Absolutely, 100 times over. This has been an amazing process. I think medicine as a field, not just ophthalmology, but medicine as a field. One of the chiefs in ophthalmology during my training, he always said, "You're a doctor first, an ophthalmologist second." So when you're, and really what that means is when you approach a patient, always approach them with that compassion and that mentality of patient care. Look at the whole patient, whether it's head to toe, and then kind of get into your specialty. Any questions regarding that first part?
No, we're good for now.
Okay, perfect. So I'm just going to go through some case studies here. So the first case is a patient who came in. Chief complaint was loss of vision. 42-year-old patient. She suddenly lost vision in her right eye over the past couple days. She complained of some eye pain whenever she moved her eyes. She denied any redness or tearing in the eye. She didn't see any flashing lights or floaters. She didn't have any other prior ocular history. No real medical history. She was very healthy. She's had a couple C-sections. She was allergic to penicillin, not really on any medication, socially very responsible, doesn't smoke tobacco, and a very occasional drinker, doesn't do any IV drug abuse. And so when we checked her vision, her best corrected vision was about 2150, so about 2 lines below the big E on the eye chart. And then she's seeing 20/20 in the left eye. When I examined her pupils, there was an abnormality in the right pupil. So when you shine the light, it actually got bigger instead of becoming smaller. So that's something that's called an APD. Otherwise, her eye movements were full. She did report some pain when she moved her eyes. When we do confrontation visual fields to kind of check how well she sees in her peripheral vision, it was definitely diminished in the right eye. The left eye was full. Her eye pressures were within the normal range. When I did a slit lamp examination, everything looked normal. This is kind of a picture of the back of the eye when we look into the back of the eye with the lens. And this is actually a completely normal exam. Her blood vessels, her nerves, her retina, they all look completely normal. So the question is, what the heck is going on? She's really not seeing well. This happened all of a sudden. What is going on with this patient? So this is a classic example of a young patient, typically female, loss of vision, pain with eye movement, and the exam is typically normal outside of what we saw in the pupil. And that tells me that there's something going on with the optic nerve. And this is actually something called a retrobulbar optic neuritis. And so the optic nerve was inflamed, and so this is very suspicious for multiple sclerosis. And so I actually had her admitted to the hospital. I had her get treated with IV solumedrol, which is a steroid medication. We had her do an MRI of the brain in orbits, which actually showed some white matter enhancement, which basically says that there are some associated signs of or high risk of multiple sclerosis, and I got a neurology consultation. The MRI showed, like I said, multiple white matter lesions with multiple sclerosis. She was diagnosed. After the treatment with steroids, her vision actually returned back to baseline. We got her hooked up with a neurologist who treated her with Tecfidera to continue to treat her multiple sclerosis and reduce her flare-ups. And, she did well. So this case, the reason I like it is because it's kind of a case where you collaborate with other specialties. You also kind of notice how you play an important part of a huge disease that's going to play a part of that patient's life, for the rest of their life. And you played a big part in diagnosing it. And, thankfully, now that she was diagnosed at an early point, I've seen her for the last 5 or 6 years now, and she's been great. So the second case is kind of a bread and butter case that we do. So patient, just a 62-year-old male, just came in complaining of some blurry vision in the right eye, progressively worsened over the past 3 months. Poorly controlled diabetic patient, denied any other problems, no redness or tearing, flashes or floaters, and didn't have any other history. His medical conditions were significant for diabetes and hypertension and cholesterol. Had his gallbladder taken out earlier, no real allergies, and he's on those medications, used to use tobacco, and not a heavy drinker, does occasionally socially drink. And so when we took a look at his exam, he was hand motioned in the right eye, so which means that he could barely see a hand waving in front of his face. He was seeing really well in the other eye. His pupils were normal. His eye movements were normal. When I kind of said how many fingers you see, he was not able to see anything like that. And this kind of happened pretty rapidly. And when I took a look at on the exam with the slit lamp, he actually ended up having what's called a white cataract. So a white cataract basically is when the lens of the eye becomes cloudy and hazy over time so rapidly, it becomes completely white and opaque. And so it doesn't even let light through, and so patients can't even see. Cataracts are age-related. They can develop very quickly in patients who have diabetes or who are on certain types of medications like prednisone or other types of steroids. And when this happens, everyone will develop a cataract at some point. And that is just a natural age-related process that happens. And younger patients will get them typically because of some of the other things that I mentioned. But a rapid development of a cataract is typically diabetic in nature and, uncontrolled blood sugars. And so, so what I saw was he had a hypermature cataract in the right eye. We got him some surgical clearance to make sure he's good for surgery. We brought him back for a preoperative appointment. So we take some measurements of the eye. So going back to optics, we take measurements of the length of the eye, where the lens is, the curve of the eye, and we plug it through some very complex mathematical formulas, which give us the dioptric value of what lens implant is going to be the best for him to correct his vision. And so we scheduled him for a cataract extraction and a lens implant. This is a lot of what I do. Certainly patients don't wait till they can barely see a hand in front of their face, but certainly this cataract appeared pretty quickly. So this is kind of a before and after of what we noticed. So the left picture here you can see kind of a completely a white area here within the pupil, and that is the lens. So you can imagine that light barely even gets through that. And so I was even surprised that the patient was even able to see a hand waving in front of his face. And then after the surgery, and again, the surgery takes about 15-20 minutes, outpatient, patient goes home the same day. We remove the natural lens that's become cloudy and hazy, and then we actually implant a new lens into the eye. This is all microsurgery. All of our incisions are less than 2 millimeters. It's pretty amazing. And the patient actually did really well. He was seen 20/20 after surgery, about a week or so after surgery. And then obviously, because he was so poorly controlled diabetic, I checked the back of his eyes, and he was doing really well. So he didn't have any changes of diabetes. So this was an example of how you can significantly change someone's life. Everyone's going to get a cataract. This is really a big part of what ophthalmologists do. But it's amazing, and it still amazes me no matter how many of these that I've done, when patients tell me, man, I didn't realize how blue the sky was, or how pretty my garden is, or, I feel so safe walking now, because a lot of these patients are elderly. And so it's really an amazing thing. And the last thing is, I'm just going to talk about the last part that I do, which is oculoplastic cases. And that really involves surgery of the eyelids and the brows, and patients who have droopy eyelids. That is affecting their vision, so they can't see peripherally. It's affecting the way they're seeing. It's causing headaches because they're constantly using their forehead to raise their brows. And so this is a lady who had a very subtle change, but in the left picture, you can see that her left upper eyelid left upper eyelid, so that would actually be on your right side, is a little droopy. It's almost covering the pupil. And so she was actually complaining of the way that it looked, and the way that she was able to see out of that eye was less, because the eyelid was almost like a window shade over the pupil. And so after surgery, she had a condition called a levator dehiscence. Levator is the muscle that attaches to the eyelid, and it allows the eyelid to lift up and retract. Over time, sometimes that muscle becomes loose. It's not that the muscle becomes weak, it's just that the attachment of the muscle becomes loose. And so the lid kind of hangs down and becomes droopy a little bit. So we do a surgery called a levator advancement. And so we make a natural eyelid crease incision. So the incision is completely hidden. And then we reattach the muscle. We actually wake the patient up midway through surgery and have them sit up to make sure that the eyelids are even, and then we'll lay her back down and suture everything up permanently. And she did great. She was super, super excited. You can tell that her surgery went great, because it's a subtle result, and that's exactly what she wanted. This is another one that we did. And so, he complained of a lot of things. He complained of the bags under his eyes, and he complained of the droopiness of his eyelids, and he can't see. And so he was actually, interested not only in improving his vision, but also improving his cosmetic appearance. And so we did a couple things for him. We did what's called a pretracheal brow lift. So I made a very fine incision behind the scalp. We went down to the brow. We lifted his brow up to where it's supposed to be. If you can tell in this left-hand picture, his brows are actually below the ridge of the superior bone here. That already tells you that his eyelids or his eyebrows are very droopy. He had extra skin of his upper eyelids as well. And then he has the puffiness there in his lower eyelids because of the orbital fat that protrudes out. Post-surgically, he looks amazing. So we did a brow lift. We removed some of the extra skin of his eyelids, on his upper eyelids. And then we also removed some of the fat and took a little bit of skin here. And now he literally looks about 15 years younger, and he's happy. This was something that's really, really fun to do. Sometimes cosmetic cases can get a little challenging just because patients are paying out of pocket for a certain result, and medicine is really difficult. It's not black and white, and there's a huge gray zone, and so you have to be very well versed and confident in your technique to be able to deliver results. And I think the biggest thing for me is spending time with the patient before the surgery, making sure that their expectations are in line with what you're thinking in terms of your results. And so you can see why my field is so cool. It really is a beautiful blend of the best parts of medicine and surgery. It offers a great lifestyle. Obviously, I'm home. I've been home for a while, so that's always a good thing. It's technology driven. It's rapidly evolving, and there's always going to be a need. Patients are always diabetic. They're going to need diabetic eye exams. Everyone develops a cataract. You're going to need to have cataract surgery at some point. People are always going to want to look youthful or look better, and so taking care of their eyelids and their brows and is always going to be a need. And there's only about 400 ophthalmologists that come out a year, from 400 to 500 in the country. So it's a specialty, especially with the booming population, that is really going to be in a shortage. So thank you so much. You can follow me on Instagram and on TikTok. But do you guys have any questions?
Yes, Dr. Patel, that was an amazing presentation. I thought that guy whose surgery was done, he looks amazing afterwards.
Yeah.
But I'll get to the questions. Mark wants to know, going back to when you were in medical school, do you remember like what the cost was for your medical school at the time and how you kind of funded that, and what would you suggest?
Yeah. So, I did, thankfully I went to a state medical school. I was, a state resident. And so, I am still paying off my medical school loans. But you know what, at the end of the day, whatever school you go to, whatever the cost is going to be, it's really going to be a drop in the bucket. And I know that it seems really daunting where you are now, and it certainly did when I was there. But I can tell you now that, I think my loans were maybe $175,000, something like that, for a state school. So it's not bad. But obviously, costs can go up, and it can be up to $300,000 of debt. But the thing is that there are great repayment programs. The government has great loan financial assistance programs, which I took out government loans. Those are always the best way to go in terms of giving you your best forgiveness options, your best interest rates, and obviously things that are out of our control, like the pandemic, they will forgive your loans or put it on an automatic forbearance, during this time. So the government-backed loans are always great to get. The second thing is that a lot of people don't know this, but if you go and say, okay, you want your loans forgiven, if you work in either a rural area or through the VA for a number of years, I want to say it's 5 or 7 years, they will completely 100% forgive your loans.
Oh, wow. I didn't know. But those could probably have to be like federally or government loans.
No, yeah, I think they're any. Yeah, I'm sure there's some restrictions, but certain. I didn't do that, but I definitely know people who did. And
That's really cool.
There are always options if you're scared about that. But even any specialty in medicine, you will be very comfortable. You'll be able to pay your debt off slowly. And these government loans are 30-year loans, so it's not. It's really not that big of a deal.
Okay.
Yeah.
Right. Thank you for answering that. Another question. concerning ophthalmologists, for someone who's in college, like looking to go to medical school, what advice would you have for somebody who's interested in like ophthalmology and optometry, like to gain experience about the field and going into medical school?
Yeah. So, certainly I would say that one thing is really important is distinguishing whether you want to go into medicine, um, or do you want to do optometry? And and the reason I say that is because if you go into medicine, meaning you want to become a doctor, then you have many avenues of things that you want to do. You could do cardiology, you could do radiology, you could become a general surgeon, you could become a pediatrician, you could become an ophthalmologist. Going to optometry school after college is also a great option. However, you are cornering yourself to just doing eyes, where you're not sure if that's actually the type of, patient that you want to take care of. And so, my opinion would be, if if you're if you're thinking that you might like the eyes but you still want to become a doctor, going to medical school is always going to be the best option, because as an ophthalmologist you're going to be able to do everything an optometrist does and more. You are the king of the mountain, and you're able to do surgery, and you're able to um, uh, diagnose patients and treat patients and work with other specialties. And so that's kind of the first thing. I think if you already know that you love eyes, and you're not really a blood and gore type of guy, maybe you just want to become an optometrist and examine patients and optically refract them, and that's totally fine. I would definitely find opportunities. If you're is he in college?
Yeah.
Okay, so I don't know if you guys have like a pre-med AMSA, or any of those types of organizations that usually have some opportunities to be able to shadow.
Yeah.
That's always a great option.
Yeah, I think shadowing probably an ophthalmologist would be a great start, and maybe going on there, maybe like a job in the clinic or something. That would be great too if you can
Yeah.
find that. Might be rare, but it's something to go into.
Yeah,
I would
and I
definitely
will
say.
tell you, that very few people actually know that they want to become X, Y, or Z. Okay. So, you want to become an ophthalmologist. Like that's what you've wanted to do since 5 years old. I mean, I really don't know anyone like that. And so, kind of starting from, a broad perspective and seeing, what part of medicine do you enjoy and want to do. I think that's a nice approach.
Yeah, that's. I think I agree with that too. Another question from Jacqueline. She just wants to know what your favorite part of being an ophthalmologist is.
So honestly, my favorite part of becoming an ophthalmologist is um, seeing the reaction on patients after they've healed from cataract surgery, or the day or the week after I see them after surgery. And these are generally very sweet older patients who have difficulty doing the things, and they're in their golden years of life, and all of a sudden they're reading the eye chart and they're reading stuff they probably haven't read since they were 16 years old, and they're not even doing it. They don't even need glasses to read that. And they are just, amazed at how well they're able to see, and they're able to enjoy their life. These are their golden years of their life. And they tell me, oh my gosh, I love bird watching. I can bird watch again. Or I love gardening and I'm able to see the beautiful colors in my garden. Or I didn't realize how blue the sky was, because, all of these
Yeah.
simple things that we take for granted kind of open up time after time after time. I mean, I've had patients who are like, I can't drive. I have to take my husband to chemotherapy and I can't drive. And so I take care of the cataracts, and now they feel safe and they're happy that they're able to, take their husband to these critical doctor's appointments, or, so these are all really life-changing surgeries that it never gets old. Even to me, patients ask me, oh, you must be so used to all this. And I'm like, I'm not.
Yeah.
I still can't get over what we're able to do after years of training and technology, and to be able to restore this gift to patients. It's awesome.
Yeah, and going off of like the surgery part, something I wanted to know about it too. I know a lot of students and a lot of college students, well, after they get 18, they look into LASIK surgery, and especially to get rid of like wearing contacts and
Mhm.
glasses. So my question about that is like, what is a good age to get that done?
So I'm very conservative. You know, I'm sure you can find a LASIK doc who's gonna perform surgery, you know, on someone who's maybe 18 or 21. I generally tell patients of myself to say, you want to make sure that you've stopped growing, that your eyes have stopped growing. Some people grow well into their early 20s. And so really 23 to 25 is a good age consideration, okay? Because
Okay.
you can tell if you're nearsighted, you may know from your own experience, you know, maybe you were a -3 and then you had a growth spurt, now you're -5. And then you had another growth spurt, and it kind of keeps changing a little bit because the refraction of the eye changes with the size and shape of your eye as you get older. And so, you know we stop growing after about 23 to 25. And if you're going to spend money on a surgery like that, you want to make sure that you're going to get the longest lasting results. And LASIK is typically going to last up until, if you get in your mid 20s, it's probably going to last up until about 40 to 45 before you're going to be in reading glasses and those types of things.
Gotcha. So definitely wait until your vision like stabilizes and you're done your
Exactly.
growing part, and then
Yep.
get it done. So it's one and done, and it
Yep.
keeps stays the
Exactly.
same.
Yep. Exactly. Exactly.
Okay. Another question from Nick. He wants to know about your current lifestyle. Were you able to find a healthy work-life balance during medical school and residency? And if you so, how'd you do that? And are you able to find that balance better now or not?
Sure. So I want to say during training, it was really difficult, extremely difficult. And I think, at least when I trained, it really was, yeah, there was an 80-hour work rule, but there's really not an 80-hour work rule. And it's not that I felt overworked. It's that there's so many patients and so many things to do that you want to get it done. And at the end of the day, it's about making sure that you're giving yourself and building the best foundation for your future career. And so, yeah, I mean, I will say residency was really, really tough. I mean, certainly I probably had 2 weekends off a month, which is not bad for ophthalmology, but then there's always things you have to do. I still have to say, my wife was the breadwinner during residency. She's a physician assistant. And so, it was really difficult, not only financially, because residents just don't make that much, and then on top of that, it being in New York City wasn't easy. I was actually commuting from Jersey, so because I
Oh
could,
wow.
yeah, I couldn't afford New York City prices. So yeah, I mean, they had subsidized housing and those types of things, but we found something in Jersey, so I commuted all the time. But so once I finally got done with training, I absolutely found a great balance. So I don't bring any charts with me home. When I come from the office, like that's it. Like there's nothing else. Yeah, I'll get a text here or there from my office manager or something regarding a patient or a refill or something like that. And you surround yourself with good people who you trust and who can take care of some of these small things. But for the most part, at this point, most of my weekends are free unless I'm on call. I'm usually home, like I said, by 4:30 to 5. I have two young kids. I don't miss any of their stuff. I go to all my son's basketball practices, his flag football practices, his golf. I see my daughter's rowing stuff. I mean, I'm able to do everything. And at the end of the day, I want to actually, it's a song I heard by DJ Khaled. The lyrics I really liked. It says that the lyric was, "Time is money," but
Exactly.
yeah, time. Okay, time is money, but Oh man, I totally
You
messed.
can't buy time with money. I think something
Yes,
like that.
exactly.
Yeah.
Yes, exactly.
Yeah.
Yes, but you cannot buy time. Exactly. So
Yeah.
you can't buy time. So I can work really, really hard and set myself up for an amazing future. But the time I have with my kids or my family or those types of things, I'm not going to be able to get that back. And so, we do a ton of stuff where I come home at a decent time. Yeah, there are definitely some busy, busy weeks where, like what I do, and it depends what position you put yourself in. When I take hospital call, sometimes it can get busy. There are consults I have to see at the hospital and those types of things. I'll finish my clinic, I'll come home, I'll hang out with my family, I'll do their activities, I'll have dinner with them. The kids will go to bed at around 8:30 or 9, and then I actually go to the hospital. So I will go to the hospital later to see my consults outside of my family time. And so yeah, you can definitely make all of this work. And a work life balance is totally possible. I work out in the middle of my day. I work out at lunch, Monday, Wednesday, Friday. So I meet up with my trainer during 12 to 1 because I don't want to take time out of my family time after work to go working out. And so, it's just how you schedule your day. So when I come back to the office at 1 o'clock from working out, I'll munch on things in between patients, and that's how I'll kind of eat my lunch. But you can absolutely have a very, very good balance.
Yeah. That's great to know. I think a lot of like students like think like, especially residency, like the competitive residencies, I think the work kind of gets done in medical school and especially in residency in terms of working those 80, 90 hour schedules. But after that, it's depending upon what you're really, really prioritizing. Depending
Yeah,
on what you prioritize,
absolutely.
you make that adjustment for
Yeah,
yourself.
yeah, absolutely. And and I will tell you, like, money isn't everything. Don't go after the money. Go after your happiness. And I think that really is. I have friends who are kind of cynical about medicine, but in my opinion, they're just looking through it through a wrong perspective and a wrong lens. I mean, I absolutely love what I do. I told you, even now in today's environment, I would do it all over again. No questions, no questions. I mean, medicine is such a amazing sacred field, and you think about what you've went through medical school and residency and internship and fellowship just to be able to have the privilege of taking care of someone, and on top of that, someone trusting you to take care of them. In my case, taking care of their eyes, or something cosmetic or something else going on. And um, you know do you if I go into a car dealership to buy a new car, I'm not trusting the salesperson. Okay. uh, you're not.
Yeah,
Okay.
you.
I can have a new patient walk into my office, never met them, and they will trust me. And that is not because of me, but that is because of the fact that you are a physician. And
Exactly.
and that is a privilege that should never, never be taken so lightly. And so, as long as you respect that philosophy and you respect that privilege, this field is just amazing.
Yeah, and I agree with that. I think you put it in very, very good words. Before we, I think we're a little bit out of, we're getting close to time. Do you want to say something before we close out? Any kind of advice or anything before
So,
we close out?
yeah, I mean, I think we've touched on a lot of things. Again, I really appreciate you guys having me on. I think this is a great forum. Please, DM me if you guys have any questions. I'm always happy to answer that. I frequently help students out. I'm on faculty at UCF as well. I teach their neuro-ophthalmology courses to the third year med students on a volunteer basis. I'm a volunteer faculty. I do that a couple times a year. I teach the second year med students. So I still know every year goes by and I get further and further away from the whole application process and kind of knowing what's going on at this current time and place. But if medicine is something that you're interested in, don't let anything stop you. You can absolutely do it. It is a difficult road, but difficult roads are meant to be overcome. I mean, that's all that it is. And whether you got a score that you didn't like or a test score that you didn't like, there's always something positive that you can look into, and there's certainly something that you can do to overcome that limitation. So don't let anything stop you. Don't say, oh man, I guess I'm going to have to look at something else. So there's certainly, especially now with social media and everything else, you have so many things at your fingertips. Obviously, make sure that you don't have any regrets. Work as hard as you can. Do everything as hard as you can, so you don't have any regrets. But enjoy your life too. Enjoy your friends, enjoy your social life with your friends, and have a good balance. I think that's kind of the biggest thing.
Exactly. That summed it up really, really well. But first of all, before I close that, I want to say thank you, Dr. Patel, for your time. We had a really good conversation, and I think all the advice applies very, very well to medicine, not just in field of ophthalmologists, but in broadly to medicine. And I think a lot of those things should be taken. I would take out a lot of those things towards if I'm somebody who's in the medical field. I think those are really, really important words to remember while you throughout the journey. But that's it from us, guys. It was for those of you who joined. It was a great call. And for some couple announcements before I close out, we'll continue to have these calls, and we'll have some next week. But don't forget, your summaries are going to be coming up due soon, in about a month, June 15th. So you still have a little bit of time, but get those together. And if you're somebody new, we've had calls in the past, so you're always welcome to watch those in the past that we've done with different kinds of fields, and we'll continue to have a broad version of calls that we do. And that's it for me. Thank you, guys. Thank you, Dr. Patel.
Thank you so much, guys. Have a great night.